Good afternoon. My name is Charles Jennings. I'm director of the Christian Regenhard Center for Emergency Response Studies here at John Jay College of Criminal Justice. And I'd like to welcome you to the March event in our Christian Regenhard Center seminar series. For those of you who were not familiar with the center, we were a first responder applied policy research center. And if you'd like to find out more about our events, we have several ways to stay in touch. You can join our listserv, which is becoming kind of quaint in this day, but we still use it. And by clicking on contact on our webpage, which is christianregenhardcenter.org. We also have an active Twitter feed at RacersJJC, and we book all of our events through Eventbrite. And so for today, we're very pleased to have a session featuring one of our collaborating faculty members, Dr. Tara Heagele, who was with the Hunter College Bellevue School of Nursing here at CUNY. And she serves in leadership roles in her professional nursing associations. She's a nurse, in case you didn't pick up on that. She enjoys monitoring healthcare trends, writing letters and making phone calls to legislators, and being an advocate for nursing. She started her program of research exploring household emergency preparedness of elderly and medically frail community members qualitatively with the hope of better understanding the reasons why people do or do not prepare for disaster in order to inform policy. And she's particularly interested in the role that nurses can have in mobilizing the community to prepare for and recover from disasters. And for anyone who's studied emergency management, or anyone who's just been watching the headlines in our latest, the COVID health crisis, this is an area that is becoming increasingly recognized as central to preparing communities and building resilience to natural disaster generally, and as well as public health emergencies. So with that, I wanted to turn it over to Tara and welcome you to the seminar. We've been having you on the affiliated faculty for several years, and we're delighted to finally get you on board doing a talk. And so take it away. It's all yours.
Thank you. Thank you for having me. I'm going to stop sharing your screen. We'll go to mine. Okay, well, thank you for having me, for all of you joining me. Before we get started, I'm going to ask you to do an easy calculation at some point shortly. You may need a pen and paper for this. I hope you don't have enough fingers to do this addition, but it is potentially that you do. So here's my objectives. We want to discuss the causes of vulnerability to injuries, illnesses, death, and disability of the elderly and medically frail in disasters. I definitely want to discuss the role of nurses in mitigating these vulnerabilities. For those of you who are not nurses, you'll understand how you can better utilize us before a disaster hits instead of just during the response and recovery phase. Learn how to use this household emergency preparedness instrument to measure level of preparedness, and learn how to implement a household emergency preparedness intervention so that we can improve preparedness of households. I also hope that you will be better able to protect yourself, your family, and your home after this presentation. And I hope that you will serve as a trusted risk communicator about the importance of disaster preparedness to your community members. So let me give you a little bit of background about myself. I'm not sure if there's a lot of emergency management folks on this call today, but I have to establish street cred, because why am I a nurse talking about emergency management? My research walks the line of emergency management, public health, and nursing. But where it all started, though, the Dr. Heagele disaster nurse researcher origin story was that I've lived through several extreme natural weather events as a child. My most memorable was the nor'easter of '92. I'm not sure if you guys remember that one. I was in 5th grade, actually. We just moved a couple of blocks away from my original childhood home to a riverfront house, literally like 2 or 3 days before that storm hit. And when the storm did hit, the entire street flooded. A house burned down like 2 houses away from my new house. I was crying. I said, I want to go back to our old house. It was a mess. So that started it. Also, my parents frequently, I would say once a year, we would spend a week down at Virginia Beach during the summer to vacation. We did a couple of hurricanes down at Virginia Beach. I saw houses knocked off their stilts. I was in one of those houses, not knocked off the stilts, but the house was swaying around. They weren't doing mandatory evacuations at that time. So I do recall that. And at 14 years old, I joined my local ambulance squad as a junior volunteer. And then I became an EMT at the age of 16. And then, if you look at the picture that says Trent, New Jersey, 2005, I put myself through nursing school while working full time for the city of Trenton EMS. And so that was one of the flooding events that we had around here. So I've witnessed life threatening events because of medically frail community members not being prepared for disasters. I just going back to my EMT days, two events were especially memorable. I remember there was a severe thunderstorm that caused power outages to most of the city where I grew up. And on this one particular night, there was a patient who had renal failure. They were doing a home dialysis treatment and it stopped right in the middle of this power outage. There was no backup generator, there was no battery backup. So this person had to get transported to the hospital. During the severe thunderstorm itself, there's a tree down on the street. It was quite frightening. You know, remember, I was a teenager back then. That was in my home city before I went into Trenton EMS. And I do remember another time that a thunderstorm knocked out power to an entire nursing home. Their backup generators did not click on. Nobody knew how to troubleshoot those generators. Actually, the staff didn't even know where they were. So we had to evacuate all of these patients in pitch dark with just flashlights, carrying oxygen tanks, carrying them down the stairs. So I was just appalled that that could happen. September 11th, that occurred when I was 19 years old. I was in college. I was a volunteer EMT on campus at that time as well. It was a boys' club. I was the only female volunteer EMT. I was the only nursing student. I didn't quite fit in. So the guys all deployed to Giant Stadium and left me alone on campus to handle EMS for all of these other frightened college students. So that stuck out my mind. Then Hurricane Katrina in 2005 hit. I had just graduated from nursing school 2 months prior, 3 months prior. And I was watching what the healthcare workers were going through down in New Orleans. The being stuck in the hospitals, the stadium, the alleged euthanasias that took place. It was just absolutely horrified, thinking to myself, I never, ever want to be in that situation. I don't want anyone else to be in that situation. Something's got to be done about this. So let's go to 2012, Hurricane Sandy. You can see that picture in the bottom corner. That's my childhood home. My parents still live there. It was completely flooded. The whole ground floor had to be gutted during Sandy. I should say shortly after Sandy. So I worked as a critical care transport nurse. You see that with the SETU. So I've been in the ambulance. Those nurses that fly in helicopters with their cool jumpsuits. I did not do that, but I did their exact same job without a jumpsuit, but in an ambulance. So my transports were often quite long. And then you'll see 2020 working during COVID. 2021, I've deployed with my local medical reserve corps to administer COVID vaccinations to community members, did that several times. So I've worked both as an EMT and a nurse in New Jersey since roughly 1999. I've either volunteered or worked through every local disaster during that time, and I shouldered the burden of unprepared community members during disasters. I and my coworkers, and if I'm being completely honest with you guys, my husband's a career firefighter, so him as well. We've all put ourselves at risk when rescuing people during dangerous storm conditions. So my research journey, which is still, kind of in its infancy stage, I'm only 4 years into academia. It started from an area of frustration. So why are these people in my ambulance? Why are these people in my ER? Why weren't they prepared? Why is it preferable to spend this time in the hospital, or should you be on your couch under a blanket with your flashlight and your cat? And I am happy to report that very, very, very quickly into my research journey, that frustration transitioned into understanding. There are so many reasons why people cannot prepare for a disaster. And now it's my role to help our community members get prepared. And by presenting this, kind of my research journey thus far to you, I hope to inspire you to start doing some disaster research as well. So I want to talk about some pictures throughout my presentation. They feature my home disaster preparedness kit and also the commercial disaster kit that I have chosen to use for my intervention studies. I put the contents of these kits in the captions under the pictures. I'm not going to talk about them, just kind of there for your viewing pleasure. I have to say, though, I have no commercial interest in these. I'm not sponsored by them. I'm not officially endorsing these products. In fact, all I do is give them my money. I'm not getting paid for anything related to the disaster kits. It's just, I'm just showing you what I have used in my own personal life. And that's it for those. So here's my disaster kit. If you saw, look at this slide before, it's in one tote, and the water case of water sits on top of it. All of that stuff on that table there fits in that one container, and I can grab that container in a precipitous evacuation. I also have a go bag in my car that has clothing and toiletries that stays in my car all the time. This one lives in my house though. So that brings us to our first poll. Before we learn how we can help community members get prepared for disasters, let's do a case study about preparedness using you as the case. So let's go ahead and see if you can vote. I see at least one person has. One more person. Okay, this person must be doing something else. So can you see the results here? It looks like 50% of this crowd does have a home survival kit and 50% does not. So let's think on that actually. Let's reflect first. Half of this crowd, which you guys might or most likely are emergency management folks. Half of you have a survival kit and half of you don't. So how do we expect our community members who don't have the knowledge that we do or the means that we do to prepare themselves for disasters? So here is a household emergency preparedness questionnaire that I developed with an amazing team. I'm going to talk more about this later on in the presentation, but to continue our case study using you as the case, I want you to go ahead and give yourself 1 point for every yes. Keep track of your points. We do have a few slides of these. So have you prepared and discussed a family emergency plan? The answer is yes, 1 point. Have you practiced or drilled on what to do in an emergency at home? Have you taken first aid training? Do you have working smoke detectors? Do you have a fire escape plan for your home? Do you know the types of disasters that are most likely to occur in your community? Do you have important family documents such as copies of your insurance policies, identification, and bank account records in a waterproof portable container or stored on a flash drive or cloud storage server? Have you signed up for a community emergency alert system? Do you have supplies set aside in your home in a kit to use in case of a disaster? And do you have do you check your disaster supplies regularly for expired items? And if you have the shut off valves in your home, do you know how to turn off the utilities, your water, your gas, your propane? So yes gets 1 point, no's are 0. Next one, again, yeses on this slide get 1 point, no's are 0. Have you planned for how you and your family would contact each other in emergency if you were separated? And do you have a written contact information of family and friends? And if there's no power or telephones, would you have a way to receive information about disasters in your area, such as with a solar, hand crank, or battery operated radio? So you'll tally up your scores for slides 1 and 2, add them together. And moving on to evacuation plans, again, you get 1 point for every yes. In the event of evacuation, have you considered safe and unsafe places in your community? Do you know if your home is in an evacuation zone? Have you planned where to go if you had to evacuate from your home? Do you have a source of transportation to leave your neighborhood quickly in the event of a necessary evacuation? Do you have family meeting place in case of a separation? Is everyone in your home aware of that evacuation plan? Do you have family and friends that you could stay with during an emergency? Do you know where your local emergency shelter is? Do you have a plan for what you'll take if you had to leave your home quickly? And have you prepared a small kit with emergency supplies to take with you if you had to leave quickly? If you have a pet, and you guys can probably hear mine now because they're barking. If you have a pet, do you have an evacuation plan for your pet? And then here's our last slide. Again, these are yes or no questions. Give yourself 1 point for every yes. So they're asking about, do you have a supply 1 gallon of water for at least each person in your home for at least a week? 1 gallon per day per person for 1 week. Do you have a 1 week supply of ready to eat food? Do you have moist towelettes, hand sanitizer, or other kind of personal hygiene supplies? Do you have a flashlight, a torch, a headlamp, lantern, glow sticks, candles, other non-electric portable lighting? Do you have a first aid kit? Do you have a sleeping bag or warm blanket for each person? Do you have cash? Do you have extra batteries, matches, a fire extinguisher? Do you have wrench, pliers, or a multi-tool that will be able to turn off your utilities? And if you wear prescription glasses or contacts, do you have extra glasses or contacts? If you have a baby, do you have a 1 week supply of formula, bottles, and baby food? Do you have a 1 week supply of diapers or nappies? And do you have a 1 week supply of pet food and water for each pet? And if your pet takes medications, do you have a 2 week supply of medications? So tally up all of your points now. I realize some of these questions are not applicable to you in the actual instrument. We tell you how to handle that, but tally up your points. And we should have 41 points if all of these questions were applicable to be considered prepared for a disaster. However, since some of them are not applicable, and you could be mostly prepared now, run to the grocery store, grab what you're missing, and then be completely prepared in 30 minutes. So I'm going to be nice and say that if you have 31 items or more, then I'll consider you prepared for a disaster. So let me activate the next poll. Okay. What was your HEPI score? All right, one more person. They might not be floating around, so we've got, there you go. 67% of our people here on this call are unprepared. 33% are, and that's actually better than normal, honestly. So you guys are doing pretty good. So again, like I said, doing some self-reflection for this case study, we presumably have good jobs. We're fairly able-bodied, and yet still we're not completely prepared for disasters. How can we expect elderly and medically frail community members to prepare? So let me give you a little background. You probably know about this stuff, so it'll be quick. There's a growing frequency of extreme weather events and man-made disasters and humanitarian crises. The greater part of the population under study, vulnerable or not, no matter the demographic characteristics or the geographic location, is unprepared for disaster. That's been shown in numerous studies. It's rare that you'll see an assessment study that demonstrates prepared population. Also in the literature, there doesn't seem to be a single accepted definition of what exactly it means to be prepared. And there's no gold standard instrument out there yet. I hope mine will be the gold standard. So household emergency preparedness, it's a public health concern. Lack of preparedness, especially in medically frail populations, consumes responders' time, and it can easily deplete community health resources. So increased levels of household emergency preparedness could plausibly save lives, prevent worsening of chronic medical conditions, and decrease the likelihood of responders having to brave dangerous situations to assist those in need. However, literature is actually lacking to support those claims. We haven't done, as a disaster research community, an experimental study looking at if you are prepared for a disaster, are you more likely to survive? Are you less likely to need assistance? Are you less likely to have an exacerbation of your chronic medical condition? Are you less likely to get injured or sick? So those types of studies are greatly needed. So disasters are always inclusive. Response and recovery are not unless we plan for it. Great quote from the FEMA Emergency Management Institute disability policy consultant. So community members with access and functional needs have special needs that should be accounted for during disaster preparedness, response, and recovery. What does that mean? These are the folks that have, this is what United States FEMA describes as having access and functional needs in disasters. Folks that are elderly, that's anyone greater than 65 years of age, and people who are medically frail, so people with serious and complex medical conditions, and those with physical and or mental disabilities that significantly impair their ability to perform one or more activities of daily living. Elderly people are often frequently medically frail. The scope of the problem is, the entire population is aging, right? And then we've got medical services increasingly being administered in the community. So this data is from a few years ago. I think after this pandemic, we're putting even more healthcare in the community. So a few years ago, 54.5 million medically frail community members lived in the community, not like in a nursing home or a rehab. 47.5 million people had disabilities and could possibly not be able to take protective measures during a disaster. And 133 million people with a chronic illness that could be exacerbated by disaster conditions. And those conditions are loss of power, temperature extremes, loss of access to their providers, all of that kind of stuff. Then we've got more people developing and living in coastal areas. On our area in the East Coast of the United States, our hurricane frequency has increased by 40%. And worldwide, there's a growing frequency of extreme weather events, man-made disasters, and humanitarian crises. So the summary of this, morbidity and mortality outcomes for the elderly and the medically frail are disproportionate to the rest of the population. And not addressing these vulnerabilities has been shown to have negative effects on both the response and the community as a whole. That's because they're less likely to recover economically from the expenses related to disasters. It makes an already vulnerable population impoverished. And then medical needs of the elderly and the medically frail, exacerbated by that disaster, become a severe strain on already stretched disaster resources. So it's important for nurses, and of course everyone else on this Zoom call, to understand what makes individuals vulnerable during disaster in order to address those vulnerabilities during the preparedness phase of emergency planning. You gotta stop being reactive, we'll be proactive. So you guys can participate, and nurses as well, in all aspects of disaster preparedness, mitigation, response, and recovery. And that brings me to my first research study, my dissertation study, actually. The purpose of it was to understand how older and medically frail adults have experienced disaster and how this experience impacts what they do now to prepare for disaster. And I wanted to generate theory regarding the process through which community members prepared for disasters. It was actually a qualitative study. It had to be, because I could not find an instrument, a household emergency preparedness instrument to use. So I can share the publication that I've cited. It goes into much more detail on the community level emergency management interventions, along with all of the evocative qualitative data from my participants. The presentation, this particular presentation today is focused on barriers and facilitators of individual and household level preparedness. So spoiler alert, though, the only participants in my study that I found to be prepared for a disaster had attended this class at the local senior center called STORM. It's called Seniors Taking on Readiness Measures. And it was actually offered by emergency management personnel. These guys would go to the senior center, they'd have a class on how to prepare for disaster. They had homework to do. They did their homework, they got a free disaster supply kit, and then they went on their way. And these were the only participants that were actually prepared for a disaster in my study. Now, let me see if I forget anything. Oh, this is what I wanted to tell you. With the volume of data that I analyzed for this study, I was able to get a few publications out of my dissertation. So they are all cited on various slides. If you want more information on different aspects, you'll know where to look. So here's my data sources. I have 31 knowing participants. So those were community members, elderly and medically frail community members that survived Hurricane Sandy. This This study took place in the city of Long Branch, New Jersey, where I grew up, and these were Sandy survivors. So my saturation, remember it's a qualitative study, we look for saturation, right? Saturation of disaster experience, motivation for preparedness actions and community interventions ended at 26. But I wanted more information on preferred information sources, so I kept interviewing. I took memos, I took field notes, I included a ton of peer-reviewed research and journal articles. I read emergency management textbooks, newspaper articles. I analyzed 143 newspaper articles. Irene in 2011, Sandy in 2012, Joaquin in 2015, Matthew in 2016, Hermine in 2016. And I also looked at Winter Storm Stella in 2017. And so I incorporated all the data that I was seeing distributed in these newspaper articles into my analysis. And then I was watching television broadcasts during disasters to see what was discussed about disaster preparedness and documentaries as well. And the purpose of collecting the non-interview data was to perform discourse analysis on what is disseminated about natural disasters with a focus on household emergency preparedness recommendations. And the discourse was that people should take responsibility for their own preparedness. We should not be relying on the government. Here's some more data sources that I had. I looked at all the household emergency preparedness educational resources that are offered, like FEMA, Red Cross, CDC, all of that stuff. Their internet postings, their brochures, their pamphlets, their posters, their swag. I looked at reports from senior advocacy groups like Help Age International, AARP. I was looking to see what they did, talked about emergency preparedness. I even attended emergency preparedness conferences. So if any of you guys get the chance to come to New Jersey, our New Jersey EPA conference in Atlantic City is a good time. Great conference, so I attended 2 of those. I went to a community festival, huge community festival, with a very heavy emergency management presence. There was emergency management folks every few stands. I wanted to see if they would discuss anything about disasters and disaster preparedness, because there was other community organizations there that were handing out, what their organization did and stuff like that. I didn't see any there though. And then I also looked at books, coffee table books of storms, nonfiction books, memoirs of Sandy survivors, and I even found a cookbook, which I have a picture of later on, a cookbook for disaster cooking, pretty much. When you don't have a heat source or a water source, what do you do with all of your non-perishable goods? I've reviewed the city's emergency management plans. I looked at public policies at the state and federal level. I looked at flood maps. And then I interviewed, in addition to the Sandy survivors, I interviewed the emergency manager of the city and a home health care nurse. And summary of my findings. This is years of work here, and I'm putting it on one slide. Summary of findings is that the coastal, urban, elderly, medically frail community members are generally considered unprepared for disaster according to FEMA standards. And that's due in large part to a lack of education on how best to prepare. Once they're educated, I saw motivation for self-responsibility of household emergency preparedness. You can expect that. And then community interventions, like distributing disaster supply kits and offering evacuation assistance, help overcome their situational impediments to preparedness. And it provides the best chance for these vulnerable community members to survive disasters. And I found too, if they're incidentally prepared, like they don't have an official disaster kit in their house, they've got disaster kit items, kind of willy-nilly all over the place. If that happens, it was largely in part to their past experience with disasters or their professional experience. For example, I had a few folks that were retired, either teachers or, like a janitor from a school, and they had set up storm shelters in the schools in previous disasters. They knew what they should have in their home from their professional experience. And here's the findings of the vulnerability to hazards. The blue font here is the physical pathways to health vulnerabilities, and the purple font is the social pathways, or are the social pathways. So one is advanced age, why people are more likely to get sick, injured, or die during disaster. With advanced age, they're less tolerant of the temperature extremes due to circulatory problems. They have a loss of subcutaneous tissue and sweat glands. They have reduced ability to perceive heat, delayed thirst, and perspiration mechanisms, and they take medications that influence their temperature regulation. The chronic illnesses that are associated with disaster, morbidity, and mortality is diabetes. Anyone who's had a stroke, a heart attack, any of the chronic lung conditions like COPD, emphysema, asthma, anyone with hereditary blood disorders like sickle cell, anyone who has end-stage renal disease, high blood pressure, arthritis, and dementia. It's because they experience disruptions in their routine medical care, and they have difficulty with gaining access to their care providers and their care facilities. 3 is dependence on others or objects. So anyone who needs assistance with activities of daily living, like bathing, dressing, grooming, using the toilet, cooking their meals, getting to medical care, if they're relying on electricity for medical devices, if they're relying on supplemental oxygen or refrigeration for medications like insulin for patients with diabetes, all of that leads to increased morbidity and mortality. 4 is mobility deficits. We think about mobility deficits mostly when it comes to evacuation. It's difficult for these folks to evacuate quickly or even take cover. And if you help them to evacuate and you make them leave their mobility device behind, like their wheelchair, their walker, or the cane, wherever you bring them to, they're going to be much less self-sufficient. So you've got to evacuate them with their devices. For 5, cognitive deficits, anyone with memory disorders, dementia, delayed reaction times, and psychological distress, more likely to get sick or injured or die during a disaster. For 6, anyone with sensory deficits, if you have an inability to see, hear, taste, or smell, you're unable to see warning signs. You don't see the sky darkening, the smoke coming through. You can't hear emergency instructions or alerts. You have trouble navigating in unfamiliar environments. And actually, these folks are more likely to eat spoiled food and get food poisoning after the disaster, of course. Lack of social support. So if you have adequate social support, then your family, your friends, the community in general, they will assist you in obtaining disaster information, evacuating, sheltering, feeding you, getting you healthcare, and rebuilding in disaster situations. But folks that are housebound or socially isolated individuals, they're less likely to receive any of that. And they may actually even be invisible to disaster responders. Low socioeconomic status. If you are elderly, retired, or if you're on disability, you're on very fixed incomes and you have poor credit worthiness. There's little room to afford disaster supplies, fuel, food, lodging related to evacuation, making protective home improvements, or rebuilding post-disaster. In high-risk geographical locations, those can be places that are isolated or places that are urban, flood-prone, if they contain poorly developed physical infrastructure or crumbling infrastructure. They have a high concentration of poverty, limited access to social services. All of that is considered high risk for disasters. And in fact, our region in the Northeast Mid-Atlantic is considered a high-risk geographical location. It's highly populated, heavily dependent on public transportation, public utilities. It's also considered the economic center of the world. So any kind of disaster that happens in our area has wide range effects for the country and even the world economy. So we're actually a target for deliberate disasters in addition to being at risk for hurricanes and blizzards and all of that good stuff. For 10 and 11, low education level and native speaking ability, both of those result in a difficulty or inability to access quality information resources. So they're going to have difficulty gaining disaster education and understanding it if they do have it. For 12, female gender. If women, we just tend to live longer, so therefore we're more likely to live in poverty and inadequate housing. Also, if there's cultural prohibitions, older women may also be less likely to evacuate to shelters that do not separate individuals by gender. Then the shelter conditions themselves, right? I hear that quite a bit. If you saw what happened in Katrina, who wants to go to a shelter? That's not a motivation for anyone. But many lack ramps, railings, health services, medications, medical equipment. They have inaccessible toilets. There's inadequate lighting, poor bedding. How do we have a 90-year-old riddled with arthritis laying on a cot at ground level, right? There could be inappropriate food. It could be excessively noisy. It promotes separation from family support. So most folks would rather stay home instead of endure these shelter conditions. And speaking of that home, that's number 14. Older folks tend to live in older homes of low structural quality with no means to make storm resilient improvements. In the past experience of disaster, if they've survived previous disasters with minimal negative impacts, they may underestimate the severity of future disasters and not take actions to prepare. So here's our facilitators of household emergency preparedness. They have to understand that a risk exists. They have to they feel that they're highly vulnerable to that risk, but also that they can do something about it. As long as whatever they have to do about their decreasing their risk is low cost. And I saw caregiving responsibilities for children and family members and pets is a facilitator to household emergency preparedness. Also, communication infrastructure is a facilitator. So we need communication infrastructure that delivers clear, concise, timely, and accurate messages about the threat and appropriate responses in a manner that people of all ages and literacy levels and native language speaking abilities can receive that message. And it's got to come through formal and informal means, such as interpersonal communications. I'm calling up my friends and family saying, hey, did you get that extra case of water? You go through social media, community organizations, local media, and other residents. And it has to come through a trusted source. That will facilitate coordination, cooperation, and adherence to recommendations and directives. And healthcare providers in all care settings need to educate patients and their families on household emergency preparedness and consequences of lack of preparedness. Especially nurses, we are the number one most trusted profession. If we discuss with our patients the importance of preparedness, they're more likely to understand and listen to us. And in fact, I just started using that healthcare provider education as a predictor variable for preparedness. And the first 3 studies that we've used that predictor on, there is a strong association between the provider providing them disaster preparedness education and them actually being prepared for disaster. Just kind of more on effective risk communication throughout, and this has to happen throughout all stages of the disaster. It's got to be unambiguous, concise, and redundant messages. Redundant meaning that if I turn on the TV or I listen to the radio or open up a newspaper, everyone is saying to do the same things. You shouldn't be looking at different news channels, and different news channels are telling you to do different things, because then people stop trusting. We want to look at print, television, radio, internet, and social religious networks. We want to take into account potential visual, auditory, and cognitive impairments. So use large font and non-glare paper. And then auditory alert sounds should be broadcast at frequencies that older adults with hearing loss can perceive them. We want to educate them, please. Remember I said in my first initial findings, lack of education was pretty much the biggest barrier to people being prepared. So we can start in school. I know in New York City, they have the Ready Girl campaign. So they are teaching disaster preparedness in the school. I hope to someday evaluate the effectiveness of this. I haven't seen an article doing that yet. So that's on my to-do list. Animal networks. Remember I said that caregiving responsibilities for animals is a facilitator preparedness. So let's distribute disaster preparedness information through pet service associations, veterinary offices, rabies clinics. Any of those places would be great. The water and power companies can distribute this information, and checking on elderly neighbors, everyone, that should foster social support. That should be a kind of a message that all media repeats over and over again. You can also educate with these free resources. Here's 2 examples. One's from New York City, and then the one on the right is from New Jersey. These resources can be downloaded for free off of the internet, and they are offered in multiple information, in multiple languages. So when you open up the booklet, it tells you all of the phone numbers for the utility companies. It tells you where the storm shelters are. How do you know if you're in a flood zone? And then it also has components where the person reading it has to input their own disaster plan. So there's going to be parts that says, if you have to evacuate, where are you going? And they'll write down, where their evacuation site is, what's the route to it, what are their health insurance, homeowners insurance, car insurance, policy numbers, and the phone numbers to reach those folks, their medical history, all of that stuff is in there. So there's a component to this where they have to fill out their own disaster plan. And I've been using these in my disaster research because if it's free, it's for me. So I will use it and you guys can as well. Just type the titles of these into Google. It'll take you to the download page. You can also email me at the end of the presentation and I'll reply with a copy. Here's a FEMA checklist off of ready.gov. This one comes, I want to say, in 32 different languages. There's a ton of languages. This is just a supply list. It doesn't have the evacuation and communication plans in there, but it's a one-page, something that could be hung up on a bulletin board or handed out. So you could use that. And then we want to offer evacuation assistance. So of course, we want to evacuate folks in advance, take their assistive devices with them, provide them transportation. In the study site where I did my dissertation, anyone could get on the bus and get transported from their house to the storm shelter in the city. So that was completely free. So that should be offered. You have to provide a host site and of course, evacuate the pets with the person. In Hurricane Sandy, the pets weren't allowed in a lot of shelters, but separating an owner from his or her pet produces the same, or at least it can produce the same grief reaction as the death of a family member. And so evacuation of pets has to be considered. If pets are not evacuated, owners will most likely risk their lives by either not evacuating at all, or then they're going to return too soon to the disaster zone to find their pets. So evacuate those pets. Let's talk about medical need shelters. Those should be made mandatory and opened prior to the disasters. I say that because during the Sandy situation, many of the medical need shelters were opened in the days after Sandy hit. So they're kind of opened too late, and they were opened in areas that were inconvenient for people to get to. So we need medical need shelters. They've got to be staffed with nurses, public health department personnel, patient care technicians. Then you have your shelter staff in there. You can use paramedics and EMTs and respiratory therapists, mental health staff for sure, and pharmacists. We should have all of those folks in the medical needs shelters. And for those of you that don't know, it's a storm shelter, but it's for people that need, extra care, more care than the average community member. So maybe they've got like a G tube in their stomach, or they just got surgery last week and they're healing from that. Or maybe they're using a CPAP to breathe at night, stuff like that. Those folks go to the medical needs shelter. And then we want to stockpile. Most medications needs post-disaster are actually for chronic conditions. So we want to stockpile the chronic medications. We want to form partnerships with medication manufacturers, medication distribution agents, and retail pharmacies to ensure that these medication needs will be met during the disaster. For implications for practice for post-disaster, we want an equitable distribution of supplies. So meals that are distributed to non-responders should be actually heart healthy and low sodium. The meals ready to eat are not appropriate for people with chronic illnesses, way too much sugar, way too much sodium. And then when distributing these meals or any disaster relief supplies, the elderly and the medically frail may not be able to tolerate standing in long lines. And so they need to have a fast track queue that should be designated just for them. We want to offer psychological care. The stress of the disaster event could elevate blood pressure, could cause confusion, alter blood glucose control, and that exacerbates chronic illnesses. So we want to have our psychosocial interventions, such as grief counseling, planned for and made available before the disaster hits. And of course, we want to aid individuals in obtaining governmental assistance, especially because most of the governmental assistance applications are now online. And some of our community members, especially the elderly, are not going to be able to navigate that. So help them out. So I just spent a lot of time talking about how the elderly medically frail are so vulnerable, but they are also assets in disaster. I definitely saw that with my participants. Many of my guys actually volunteered their time in the supply distribution centers. They handed out meals and supplies. They helped with community cleanup. They should not be viewed just as helpless and vulnerable. They can be your trusted risk communicators. They have advice and experience from past disasters. They can instill hope in the younger generations. We've lived through this before. We've rebuilt before. we're going to be okay. We're going to get through this together. They've also been known to look after supplies, the sick and injured, the orphans and children, other dependents, while I guess more able-bodied folks go out and do the demo work and the cleanup out in the community. And many have traditional survival skills. So utilizing and protecting the elderly and medically frail before, during, and after disaster will actually enhance community resilience overall. So that was study number one. And remember, I had to do it qualitative because I couldn't find an instrument. So that leads me to the Household Emergency Preparedness Instrument, also known as the HEPI. The HEPI assesses whether specific preparedness actions have been taken and the presence or absence of essential supplies that could enable households to safely endure conditions that disasters would likely present, like loss of power, limitations on water, lack of access to additional supplies for at least 3 days post-disaster. So accurate assessment of preparedness levels is critical for effective planning and necessary to enhance health promotion, prevent injuries, and promote disaster-related community resilience. This is the HEPI development team, a group of amazing disaster nurse researchers. I call us the disaster nurse researcher rock stars. So this isn't my instrument. I definitely developed it with a whole team. It's not called the Heagele emergency preparedness or instrument. It's called HEPI. It was a team effort and it was an international effort. I'll show you guys that in a moment. So here, this is my first ever article published, and I published it while I was still a PhD student, and it was part of my literature review for my dissertation study, where I did find that there was no gold standard instrument to measure preparedness, and I also found that there was no evidence that actually preparing for disaster does anything good at all. Anecdotally, we know that it does, but there was not experimental studies to show that. So I typed up this opinion piece and it got published in the American Journal of Public Health. Super proud of that. So upon hire at CUNY, I repeated the literature review and I still found no gold standard instrument. And I knew that I needed this instrument for my program of research. So the purpose of the HEPI is to generate, the purpose of the HEPI study was to generate a consensus on the concept definition of what exactly does it mean to be prepared for disaster. We wanted to use experts representing multiple disciplines and countries, along with community stakeholders, to develop this all hazards, global, international, valid, and reliable instrument. The HEPI questions were developed using 3 sources of data to inform consensus. We did literature search, we used existing instruments, and then we did an international expert panel via a Delphi technique. So literature search, we found 52 articles. None of these articles were specifically instrument development publications. When selecting an instrument for your research, that's something that you need to evaluate when you're choosing your instrument. Only 22 of those 52 articles actually had any kind of instrument development information at all whatsoever. And for the researchers who created their own instruments, which was pretty much everyone, the FEMA recommendations continued to be the most popular to inspire the instrument questions. Then we used existing instruments. So one of our team members, Dr. McNeil, she had developed an instrument for her work. It was called the Preparedness Index. She used it in 2 studies. We used that as the baseline instrument. And then we added questions that we found in other people's instruments. And then after the literature search and review of the evidence, we agreed that a gold standard household emergency preparedness instrument had not emerged since the article was published. And then we proceeded to do this instrument development via a Delphi study. So we assembled the instrument for the Delphi study participants to evaluate. Why this Delphi technique though? It's really good if the participants don't have a history of adequate communication, and if we need input from more individuals that can effectively interact in a face-to-face exchange, if time and cost make frequent group meetings infeasible, and if we need participant anonymity to reduce the effects of dominant individuals, which is also known as the bandwagon effect. So Delphi studies, they're fast, they're inexpensive, and they're versatile. In fact, I did mine with no funding at all whatsoever. We have the ability to condense the opinions of many experts into a few precise statements. People respond on their own time. They don't have to show up to a meeting somewhere. And the anonymity allows for participation in kind of a non-adversarial environment. Delphi studies are actually commonly completed with under 100 participants, and we had more than that, so that was good. We did our recruitment via email, and the compensation that we told our participants was that they were going to have free and open access to the instrument once we were done. But in fact, everyone has free and open access to our instrument. You guys can all use it in your program of research as well. So we wanted disaster experts, we wanted community stakeholders, we wanted the age of consent was 21 because that is the highest age of consent worldwide. It had to be English reading. And we targeted the corresponding authors of the articles that we found in our literature review. We targeted our interdisciplinary colleagues. The World Association of Disaster and Emergency Medicine spread our recruitment message, and we used the snowball sampling technique. Our initial instrument that we assembled for them was 106 questions long. We asked the participants to rank each one of those questions from 1 to 5. 1 was unessential, like get rid of it, it's a garbage question. 2 was a little important, 3 was neutral, 4 was important, and 5 was absolutely essential, this will save your life. And we considered consensus on a HEPI question if it achieved 80% of the participants' votes, falling within 2 categories based off of that 5-point scale. So 1 to 3, it was, non-essential, and then the 4 to 5 responses were essential. Okay, so they were asked also, should we have subscales on this instrument? They were asked, how much food, water, and prescription medications and medical supplies is considered prepared for a disaster? Is it 3 days? Is it 1 week? Is it 1 month? What is it? We asked them, how should respondents answer the questions about the disaster supply kit items? And we also asked them, how should the instrument be scored? We included 2 open-ended questions. We said, if a supply kit item is named something different in your community, because remember, this is an international study, please let us know. And that's where your diapers versus nappies come for, and all of your portable electric lighting, also your coolers, all of those things go by different names in different countries. And then we also asked them, did we miss any preparedness items or actions? And then we gave them a demographic data form. So the results, we had 178 participants. Only 131 actually left their email addresses for the prospective rounds, but 178 was good for the initial. We had 34 different countries represented. 87% were experts, 12% were community stakeholders, and look at all of the different disciplines that were represented in this. Here's a kind of a pictograph of the different countries, 34 different countries. So we didn't have anyone in South America on that continent. No, none of those countries participated, or Russia, but pretty much the rest of the world had at least one person participate. So here's the results of round 1. No items, none of the questions achieved consensus to be discarded off of the instrument, but 35 items achieved consensus to move on to the pilot test. Participants agreed that there should be subscales. How much extra food, water, medication, and supplies did not achieve consensus at all. And it was undecided how respondents should answer questions about supplies or how the instrument should be scored. So we asked them these things again in round 2, but we eliminated the response options that received the lowest votes in round 1. So that we decreased the response options. For round 2, 6 new items were added due to the qualitative data from round 1, and you can see them right there. 18 items were edited due to the qualitative data. Right, so going back to the first bullet point, work gloves was the only supply kit item that was added. And for round 2, we actually forced them into a binary response, no more 5-point scale. We said to them, is it essential or not? Pick one. So results for round 2, no items achieved consensus to be discarded. We had 84 participants at this round. 14 more items achieved consensus to move on to the pilot study. It was decided that food and water would be 1 week's worth to be prepared for disaster. Prescription meds and medical supplies would be 2 weeks worth. And then they said how we should have the response options for disaster kit items is they could say, I have this item in my home, I have this item in my disaster supply kit, I do not have this item. And then, and by the way, that gets at incidental preparedness versus purposeful preparedness, if you understand what I'm saying. And then the scoring, they wanted it to be weighted in terms of the importance of the action or item. They actually ultimately discarded that recommendation for at least the current version of the HEPI because it became too confusing. We want anyone to pick up the HEPI and understand how to score it. So that's gone, but you might be able to use it that way in your own research. So round three was really actually to help us determine how we should score the instrument. We did assemble the instrument that was going to be pilot tested. We got questions that should be weighted higher versus lower. Obviously, the things that were more essential than food and water would say be the highest scored things. Like you've got to have that to survive. Do you really need a flashlight to survive? I don't know. It would be nice. And then our final sample for round three was down to 79. So that brings us to our pilot study. The next step in instrument development is to pilot test and refine the instrument. We wanted a diverse sample, allowing for usability, for assessment of usability, reliability, validity, and culture bias of our instrument. So we did a cross-sectional study with a sample of New York City residents during the COVID-19 pandemic. It comprised of a demographic assessment, the HEPI, and inquiries to assess the ease of use. And we did this with City of CUNY faculty, staff, and students. Oh, this was a nightmare, by the way. Just for those of you who are students, just talking about or just being honest about the whole research process, we achieved IRB approval for this study like a week before lockdown. So we started deploying the instrument during lockdown, the very start of lockdown of the pandemic. And the IRB requirements were that the deans and the department heads were kind of gatekeepers. So they had to forward my recruitment message or not. It was their choice. I had no power over that. So many people said, no, this is the wrong time to do this. The staff is very anxious. I'm not forwarding it. So I think if we did this pilot study not during lockdown, we might have had more participants, but we still had a pretty good turnout. So we wanted to examine the validity of the new scales. We did that with factor analysis, and we had qualitative and quantitative data analysis performed on the respondents' experience with taking the HEPI. So we asked them, to rate the perceived clarity of the HEPI, instructions and questions, the difficulty of the HEPI, and the reasonableness of the length of the HEPI. And we also included one open-ended question, that was to inquire about anything the participant would like the researchers to know about the experience of completing the HEPI. The results, we completed our analysis with 284 faculty, staff, and students. Our internal consistency reliability was strong. It had a Cronbach's alpha of 0.89. 0.80 to 0.89 is actually considered very good. Greater than 0.90 is considered excellent. So we're so close, right? Remember, this is the pilot test, brand new time that we're using this instrument. And then for factor analysis, for those of you who don't know instrument development, the key concept of factor analysis is that multiple observed variables, i.e. the HEPI questions, we want them to have similar patterns of responses because we hope that they're all associated with the latent variable of disaster preparedness. You can't directly measure that, right? So we had our factor analysis explain 35% of the sample variance. With factor analysis, the higher percentage of variance explained indicates a stronger strength of an association between those HEPI questions and the concept under study, which is household emergency preparedness. So ideally, the variance should be 60% or higher. Ours is only 35, which is still pretty good for a social science instrument and also a brand new instrument. But we fully anticipate that as this instrument is used more and more and revisions are made, that the variance explained will increase. And the results. So who is the best prepared? And that's, I say that with hesitation, because look, the mean HEPI score was a 15.2 at 8 out of 40 possible points, 40 meaning that they're the most prepared. But the faculty and staff, older age, the higher income, and those with previous disaster experience were higher prepared than everyone else. And then the respondents, this is good if you want to use this instrument for, you'll know about researcher burden and respondent burden, right? It's low for our instrument. 92% of our guys said that the instructions were extremely clear. 87% said the questions were clear. 78% stated that the length was reasonable, and 76 said that the experience of taking the HEPI was easy. We did have quite a few right in the qualitative. Remember I said we had one open-ended question about what is your experience of taking the HEPI. A few of them said that it caused anxiety. Again, it was right at the start of lockdown. People were wiping out all the shelves in the hardware stores and the grocery stores. But based on that feedback, in the instructions for future researchers, when you're using this instrument, we do ask that you disclose to your IRB that taking the HEPI could cause feelings of anxiety and unpleasant memories of past disasters. I've already submitted that statement to my IRB for the next study. They said that's fine, it's still minimal risk, but something to consider. Also, the qualitative data revealed that the HEPI helped respondents learn what's needed to be prepared, made them realize they were unprepared, and inspired them to develop a household emergency plan. So this instrument is actually serving as an intervention in itself, right? Just the experience of taking it. So we also make a recommendation for future researchers that at the end of the HEPI, provide a link to, whatever your local disaster education website is. And that could be FEMA, it could be the CDC, it could be the Red Cross. If it's outside of the country, whatever your local disaster preparedness information source is, include that link, because people have taken the survey. They're like, oh, this is bad. I'm not prepared. What should I do to get prepared now? And they click on their link and they know what to do. So we've got construct, criterion, face, and content validity support for the adequacy of our HEPI to capture our essentials of a household emergency preparedness. So implications for practice, the HEPI is a valid and reliable instrument that provides researchers and community planners a replicable approach to assessment of preparedness levels, and it can be used for policy development. You can use it for mitigation strategy planning to decrease disaster-related morbidity and mortality and increase resilience for individuals, families, and communities. You can use it to assess preparedness levels of any population and provide evidence to support interventions and address health needs of community members following disasters. Some implications for research, the next steps for the HEPI. And any of you guys can do this, right? It's not just me. I've got so many studies on my to-do list right now, I can't do them all. So this is something that you could pick up. We need a predictive validity study. I keep saying that over and over again. We need to see if there is an association between being prepared for disaster and decreased morbidity and mortality. If we can establish that association, we can advocate for funds to help hand out these free disaster kits to help our community members that can't afford to build their own kits. We want to do a known group validity evaluation. We haven't done that type of validity testing yet. And also a retest reliability assessment. We should do that as well. So those two are quick and easy things that you guys could do. Researchers, emergency planners, and educators may use this HEPI for non-commercial purposes. Okay, you can't make money off our instrument, but you can use it for non-commercial purposes without any cost at all whatsoever to you, under the following conditions. You do cite us in your publications as the HEPI developers. If you translate the HEPI or you alter it, modify it in any way, disclose that in your publication, but also let us know, because if your changes are most likely going to make the instrument better. So we want to incorporate that into subsequent versions. And also always do the psychometric data analysis for the instrument, especially in your publications. People need to understand how it's operating in the real world so that they can make a judgment if they want to use a HEPI in their research. And like I said, all of that information will inform future modifications of the HEPI. So for a copy of the survey and the instructions on how to administer it and how to score it, you can contact any one of us. All right. So last topic pretty much of the day, nurses taking on readiness measures, also known as NTWRM. NTWRM is a nurse-driven household emergency preparedness intervention that I hope to offer in the hospital setting to older adults, people with chronic illnesses, caregivers of medically frail patients, and new parents. This was modeled after that community intervention I already told you about, STORM, seniors taking on readiness measures, that was taught by emergency management personnel at the senior centers. Those guys at senior centers are pretty healthy, they're mobile, they've got a good social support system, they're really active. So we want to target the folks that are, more sick, more isolated, homebound, those folks. But NTORM is an all hazards disaster preparedness intervention. So it's possible to replicate this nationally. We did our first NTORM pilot study in a hospital in Brooklyn, and we did it with the NICU, which is the neonatal intensive care unit, and the newborn nursery. We did it with those parents there. So the Hep B, so my dissertation study, the Hep B Delphi study, and the Hep B CUNY pilot study were all done with no funding at all whatsoever, free. I was able to do this. For this study, not so much. We were funded by Weill Cornell's medical colleges, Clinical and Translational Science Center Pilot Award seed funding, and we did have 2 research assistants that I'd like to acknowledge. So the aims of our pilot study, we wanted to expand that reach of NTORM to the vulnerable populations. And we also wanted to evaluate the effectiveness of NTORM for increasing levels of preparedness and as evidenced by knowledge and behavior. So this NTORM intervention enables the household to meet federal emergency management recommendations for household emergency preparedness. It enables them to safely shelter in place or evacuate quickly with their supplies if needed. Here's an inside look at the bucket that I use for my intervention studies. I like this bucket because it can be converted to a toilet if the sewer services are lost. When you're in a city with high rises, a lot of times during disasters, power outages, the pumps stop working, so you lose sewer in those high rise buildings. So we can use this as a toilet instead. And here's the contents of this commercial kit. So it's got everything that I put in my own household disaster kit, but in more condensed a format. So you've got your multi-tools, ponchos, your whistles, your light stick, all of that stuff is in there. They've got water in little baggies, but they also have water purifying tabs. And here's your food rations. They've got all food rations included. So here's our methods for NTORM so that you may replicate the study in your populations. This is still a brand new intervention that can be brought to anywhere that you choose pretty much. You can do this one-on-one with people. You can have it in the classroom format. You could do it via televisit. However you want to do your NTORM intervention, you can do it. So what we do is we first administer the Hep B to determine baseline level of preparedness. Unfortunately, during my NTORM pilot study, I was still developing the Hep B. So we used the FEMA checklist as our instrument, not a valid and reliable instrument. I had to disclose that in my limitations. From here on out, I'm using the Hep B though. And then you can provide the information. For us, the nurses educated the participants on that Ready New York My Plan booklet, provided guidance on how to complete that booklet. The parents did that on their own time during the hospital stay. The nurses would then check for completion of the booklet. Did the participants do their part of the homework? If so, then they received a complete disaster supply kit for free. And then we administered the Hep B again to determine change in level of preparedness. So we also did collect qualitative implementation data from the nurses. We asked them, like, how did that go for you? Do you have time to do that? Was that a good, meaningful intervention? Can you do that in your practice going forward? Results, we had 68 new parents. That was all we could afford with our limited funding. All of the funding pretty much went to the disaster kits, by the way. Those ones that I showed you, they run between $105 and $111, depending on the demand, the market demand for disaster kits at the time. So we had 68 parents and 3 of our nurses participated. And the mean Hep B score, I should say, the mean FEMA checklist score went from a 14% to 97%. Pre-intervention to post-intervention, 100% would have been perfectly prepared. The barriers was the weight of the kit. So in this specific setting, we had new moms here that were not permitted to lift heavier than, I think it was 10 pounds. The weight of the kit is 23 pounds. So that was limitations. They had to have somebody help them go home. Anxiety of the parents, of course, we did this pilot study in the middle of the pandemic. So the parents did express anxiety about not being prepared to bring a child home in the middle of the pandemic, let alone prepare for a disaster that might not ever happen. So that was a barrier. And then the nurses reported that they frequently needed to follow up with the parents. Like, did you complete your booklet yet? Are you done with your booklet? can I check your booklet? So that was a mild irritation for the nurses. The facilitators were the actual booklet and the kit. The nurses said if they didn't have those available, they probably would not do this intervention. They were necessary. However, their part in the intervention was fast. It only took them 5 or 10 minutes to go through that booklet and check for completion. So if you're not offering like a full-blown class on it, this could be a quick and easy intervention. And the cost was around $112 per participant, which sounds hefty, right? But say one of these infants. So infants are extremely, especially our NICU babies, if they're exposed to temperature extremes or poor air quality and say like a storm shelter type scenario, they get sick, real sick. So we need to compare that $112 intervention to the cost of a hospital stay if they got sick during the disaster. So the implications for your research, we want to pilot test this end-to-end intervention in other patient populations and settings. Evaluate now. So we asked the nurses what was their experience with providing intervention. Now we want to ask the participants, what's their experience? Did they find it meaningful and helpful? And again, we want to do those longitudinal studies to determine the association between preparedness level and disaster resilience. So the nurse's role, these are my last few slides, and then I'll open it up to questions. Nurses as leaders in disaster preparedness and response, a call to action appeared in our Journal of Nursing Scholarship in 2016. And the purpose was to develop a vision of the future of disaster nursing for disaster events and public health emergencies. We see nurses in disasters, it's usually us evacuating hospitals or taking care of the sick and injured. And it's rarely discussed what our role is in preparedness, right? So we wanted to develop a national set of disaster nursing competencies, integrate opportunities into multiple delivery platforms in schools of nursing, and continuing educational opportunities. Want nurses to possess the minimum knowledge base, skills, and abilities to respond to disasters, prepare for them. And of course, we want nurses to be able to respond directly or provide indirect support, like a shift courage for other nurses deploying. So for the non-nurses in this room, utilize us, invite us to your disaster drill, help us disseminate disaster education. Coming soon, I'm currently doing a systematic review on the effectiveness of household emergency preparedness interventions with an international team, interdisciplinary team as well. You can see the authors listed there through Cochrane Library. So we just concluded data extraction and now we're starting data analysis. Spoiler alert, interventions do improve preparedness, knowledge, actions, and behaviors, but we still don't know if it improves survivability. Here's my references. Hold on. Looks like I'm skipping stuff here. I am. Let me go back real quick. So we want nurses to always promote preparedness amongst individuals in their care, and that includes families, communities, and organizations, and demonstrate a commitment to professional preparedness. Here, this says nurses' role, but this should say everybody's role. So I'm taking you out of your academic role. I'm taking you out of your researcher role. I'm putting you as like the good neighbor. You should serve as a trusted risk communicator. Tell people in your life the importance of disaster preparedness. Be the good neighbor. I'm not telling you to go and host your elderly and disabled and frail neighbors in your house, but go to your neighbor and say, hey, can I pick up a case of water for you at the store and offer to carry it inside for them? Help them out. Say, can I drive you over to the storm shelter? Of course, everyone in this room can participate in disaster drills. So tricky trays and gifts in general, whenever I'm asked to contribute something to like a charity auction, I always assemble a disaster kit and give that. And also just gifts in general, like graduation gifts, housewarming gifts, wedding gifts. Who doesn't want a disaster supply kit, right? They make get great gifts for every single occasion. If you have like a church project, a Boy Scout project, Girl Scout project, nursing, our honor society, Sigma Theta Tau, you can assemble disaster kits and hand them out to vulnerable community members. And the biggest thing that you could do is actually be prepared yourself, because then you're going to be less likely to be a burden on the community. So for questions, here you can find me on ResearchGate, on Twitter, on LinkedIn. I'm pretty friendly, I think. all my references. I can share copies of these with individuals. I can't post them publicly because they're not open access. One of them is open access. The other ones I have to email you. And that's what I got.
All right, Tara, that was a lot of information. I mean, I knew you were doing all this work, but you put it all together in one package. I mean, you're like a one-person industry here, and it's really impressive. And I have to say that the research, it's well conceived, and boy, you are a workhorse. You've really done some impressive work in this area. So congratulate you for that. So as Tara indicated, please submit your questions via chat. And I just wanted to, I guess the first question was, where does this stand in terms of, I know you're doing a lot of work with the nursing profession and outreach, and where does that stand in terms of those efforts?
Well, like I said, I'm still pretty new in my academic career. And getting any research done over the last 2 years has been horrible. A couple of my studies were on hold. And in fact, I was doing my next NTORM study on a telemetry unit. Like, it's a step down unit in the hospital. Like, folks are not sick enough to be in ICU. They're not well enough to be on a regular floor. And I had to pull out of that study because they had like a 60 or 40% employee vacancy rate, a bunch of travelers. Nobody wanted to do the intervention or cared about it. So that was disheartening. So now I'm doing an NTORM study with community members. I'm trying to recruit 30 right now. But I guess the biggest part is doing stuff like this presentation here. I'm presenting something similar in about 2 weeks to a nursing audience. I want people to know about the instrument. I want people to know about this quick and easy intervention so that everyone else can start doing this as well. And it doesn't have to be researchers. It just could be public health people, emergency management people in their normal daily basis. But that is my goal. Get this stuff out there, show that it's easy to do, it's inexpensive, and encourage everyone to do it.
Okay, we have some questions coming in. The first one was, and I'm sure we'll send this around. We can send a link, but how do people find the instrument?
Easy. They like it. I mean, and that's not.
No. How do I mean? Are there participants? How do they get a copy?
Find it?
Yeah, how do they find it?
Yeah, so you just email me.
Okay.
And I could put let me put my email in the chat box, and I'll send you a copy of it.
Okay. So let's see. So we've got another question here. And everybody, please send your questions via the chat feature. How successful have you been in mandating emergency preparedness in nursing curricula and in other health professions? I mean, the poor Tara's just trying to save the nursing profession. She can't do the whole health field. But go ahead. How is that working?
I think it's working well at Hunter College. I teach a disaster nursing elective to the undergrads. I've done it 2 years now because it was just approved 2 years ago. And it's popular. It's full. That being said, I should probably do a knowledge effectiveness research study in my actual class so that I can share that with the nursing curricula world and say, hey, this actually improves disaster knowledge. I don't know if it improves willingness to respond during disasters. I'm sometimes trying to read the room and possibly gathering that I'm dissuading some of the students from becoming ER nurses, because the ER nurses are the frontliners. Like, they get everything first. But again, that is just me thinking I'm reading the room. I need to actually evaluate, am I actually making a difference? Do these people want to go into disasters now after this class? But yeah, I share that. I talk about that, with other colleagues in other institutions. We definitely have disaster nursing courses starting up around the country. For nursing curriculum in general in the United States, they do mandate that we talk about disasters. But usually it's like one class in one semester, they'll hear about it versus a full-blown semester of it as, say, an elective. So they're hearing about it, just not enough.
Okay. And I know we've talked independent of this event about looking at curricular issues across CUNY. And, as you point out, New York is a disaster-prone city. And I would, going back to even Sandy, um, I think we looked casually at that, and I think I think there were 33 fatalities in the city during Sandy, something like that. And I think 3 of them, or maybe even 4, had a direct connection to CUNY.
Oh,
They were CUNY students. And so we are very much in and of the city. And so this is a really an important area, and one that we all should recognize across the health professions, as well as obviously emergency management. So what are your thoughts in terms of, if you are the emergency manager, and one of the things we're cognizant of is this kind of disconnect, if you will, between the world of health and the world of emergency management, as much as we try to get over it. And you would think in the midst of COVID that it would be stronger now than ever, and it still kind of exists there. What advice would you give for the emergency management community to try to engage more seriously around these issues?
yeah. So for emergency management, again, I would say utilize your nurses in your community. I can't tell you guys enough. We are the #1 most trusted profession. We say that disaster preparedness is important. Folks will probably listen to us. So empower the nurses in the community with the tools and the knowledge to help spread that information. The regular nurse doesn't know what I know. In fact, there's only a few of us disaster nurse researchers throughout the world. So we are trying to get the word out to nurses, but I don't know how to explain it. Other than that, you've just got to use your nurses, of course. You ask us our opinions. Maybe even use, our home care nurses. In my study setting for my dissertation study, the home care nurses didn't talk about disasters at all whatsoever. And I feel like that's something that should be top of their thing. If somebody's sick enough to require a home health care nurse, and as a disaster hits and no nurse can actually get to that person, who's taking care of them, who's giving them their medical supplies? The organizations had nothing to do with that. They didn't get extra supplies. So I would ask emergency managers to work with any kind of healthcare facility in their community to get the word out. Where are the storm shelters? How do you get on the priority utility restoration list so folks that have medical needs can have priority restoration of their power or their water? Especially if there's a pocket in your community where there's a whole bunch of them, then they're going to send out their trucks and their personnel to go fix what's broke there. So that's what I can think of for sure. Hopefully
Okay.
answers that question.
No, that was great. One question I've got is what funding sources have you been? What's your go-to in this area, or is this falling in the cracks between kind of existing research funding streams?
Yeah. So it's funny. I just had that conversation with you right before this talk. I just got regret. So I'm going to be completely honest. I'm always candid. Right before I signed on to this, I got my reject letter for an EPA grant, not interested in the preparedness work in the way that I was proposing. And that was the first really big grant that I actually applied for. So I got rejected. For me, I don't know. I'm still learning. I've been applying for little grants. I've got 2 CUNY grants. One's $40,000. It's a climate change study. So we're looking at heat stress and air pollution and how does that affect, that's another study I didn't even talk about, right? How does that affect the physical aspects of the person? So we're doing that. And then I got some little grants to purchase the supply kits, but haven't done much else because these projects are consuming my life.
Well, they're certainly worthy, and so we should commiserate on that, and
Yeah.
we should talk, because these are, so central to notions of emergency preparedness, and so timely. It would seem to be an area that ought to get more resources, right, along with all the other research streams that are out there. Okay. I'm not seeing any questions coming in, but please feel free to send them in. We'll go for a little longer here. One question I had is, you talked about earlier in the presentation the informal networks for distribution of information and how important that was to uptake. And I think you made an excellent point with the fact that, what a household emergency kit looks like and what it contains, the fact that there's so many variations of that out there, right? Does that undermine the message? And maybe that's an area where we need better consensus, or at least some guidance. And of course, but when you talked about the social networks, I was immediately drawn to the positives. Obviously, if you look at faith communities and neighborhoods and extended networks, senior groups, but also the downside of that in terms of potential misinformation, as we've seen around COVID, vaccination, and all that. And so, have you encountered that or had any thoughts about it?
The informal networks, I know one of my participants from the dissertation study said each one teach one. That was one of my themes actually in that study. So you have to find the best way to educate them to spread the correct information. In the groups that I'm thinking about, they're not necessarily on the internet so much. So even if it's just posting a disaster kit, the FEMA disaster kit checklist, stick that in the bulletin board in the community room or slip it under people's doors, stuff like that. Again, equipping all of our faith and community-based organizations with those materials. You guys can volunteer to do a talk at your church if you want to. The that Ready New York book, if we have a New York crowd in here, they'll print that out nicely for you for free and ship it to you for free. So you don't even have to download it off the internet if you want like a nice version of it. So just getting the word out there. That's all I can recommend.
Okay, great. And so next to last question, is there anything else you want to share with the audience before we?
Going back to the funding, that systematic review that I'm doing, so with NIH grants in general, they don't want to fund you for stuff that's not kind of proven. So we're hoping to build evidence that interventions work with that systematic review, and then I'll combine that with the pilot studies I'm doing NTORM, and then hopefully I'll be applying for bigger funding soon. But right now, that's all I can think about. And other than that, I'm open to collaborations. I'm not sure I can accept collaborations at this time because my dean of research told me to take some things off my plate before I accept more projects. But that doesn't mean that you can't use the instrument. It doesn't mean that you can't do your own NTORM. I'm happy to share that kind of stuff with you. But I hope you all stay in touch.
Well, thank you, Tara. That was really a wonderful presentation, and I'm delighted to see that you're doing that Cochrane review. And for those of you who aren't familiar, that really is the gold standard. That is a big deal, and you're the second author on that. That's really something to celebrate, and we look forward to that coming out. So, keep up the good work. We're going to stay in touch. And for those in the audience, so we will post this video probably within a week, and if we want to distribute some links, Tara, we could do that also. Some materials can go out at that time, and then I would just like to remind the audience real quickly of our next event, which is April the 20th. We're going to be having a panel discussion on technology innovation in the public safety sector. And we're really pleased we have a really strong panel of academics, researchers, and practitioners who are actually innovating in this space. So we look forward to having everybody there for that. And so with that, Tara, once again, thank you so much. And thank you everyone for attending.
Thank you, guys.
Okay, bye-bye.